Since 2001, the McDonald Criteria has been the gold standard for diagnosing MS. Welcome to this week's edition of Ask an MS Expert. I'm John Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 100 countries around the world with the news that people affected by MS need to know. My wife, Jean, lived with progressive MS for 23 years. So I've had a front row seat experiencing all the ways that MS can impact a family. Today, I'll be asking our expert the questions that you want answered. Please feel free to post your comments and questions on Facebook, YouTube, or Twitch. MS Navigators will be online throughout today's live program, answering your questions and connecting you to resources. I'd like to acknowledge and thank today's sponsor, Novartis. Support from MS community partners helps the National MS Society reach its goals, including providing up-to-date information and support through programs like Ask an MS Expert. The updated McDonald Diagnostic Criteria will help doctors diagnose MS faster and more accurately. When MS is diagnosed earlier, people can start treatment sooner, which can lead to better health outcomes. Joining us today to discuss the new criteria and how it may impact the MS community is Dr. Andrew Solomon, neurologist, professor, and chair of the Department of Neurological Sciences at the Larner College of Medicine at the University of Vermont. Welcome, Dr. Solomon. Thanks for being with us today.
Hi, John. Thanks so much for having me.
Well, I hope you'll start us off by explaining why MS needs diagnostic criteria.
That's a great question. Diagnostic criteria are incredibly important in medicine, and often they exist when there's not one test that can help us diagnose a particular disease or disorder. So some diseases may have a single blood test that'll help us confirm somebody has a disease, and it reflects something about that disease process often. Whereas in MS and a lot of other disorders in neurology and other fields, require sort of an amalgamation of different findings on a neurologic examination, MRI, perhaps CSF, spinal fluid, that help us inform the diagnosis of MS. And this ensures that when doctors give somebody the diagnosis of MS, that they're all thinking about the same criteria and to confirm the diagnosis. And especially when we start to develop research where we're testing treatments, we want to make sure that we're testing them in treatments that meet this criteria for MS to make sure that patients who fulfill the criteria will respond to those treatments and they'd be the right patients to receive those therapies if they work.
Are there other methods or criteria commonly used to diagnose MS beside the McDonald Diagnostic Criteria?
McDonald criteria refers to some changes in the diagnosis of MS that evolved in the early 2000s, where we started incorporating new tools to help speed up diagnosis, including MRI in particular. So while MS was a purely clinical diagnosis and had some other diagnostic criteria starting in the 60s that most people agreed upon, initially called the Schumacher criteria, the criteria have evolved over the years. And I think the McDonald criteria are really the consensus criteria that MS specialists use now to make the diagnosis of MS. It's incredibly important to have one criteria because we want to make sure we're all talking about the same thing and that the research we do to help patients with MS also uses the same criteria, so we know that it helps those patients.
I'm glad you mentioned that the criteria have evolved over time. I was about to ask you whether the McDonald criteria have been updated before and what's different in this latest update.
Great question. So the MS diagnostic criteria or the McDonald criteria has been updated roughly every 7 years or so since 2001. And what's driven these changes has been new data or new research that suggests there may be ways to diagnose patients earlier. And so that research accumulates over time, and then this committee meets and decides what's ready to be incorporated in the diagnosis of MS, or in the diagnostic criteria, rather. And so there have been a number of changes over the years that have facilitated earlier diagnosis in patients than we were able to achieve in previous criteria. Now, thinking about the 2024 criteria, the upcoming criteria, I think that the easiest way to think about the changes broadly are that there's a variety of new diagnostic pathways. So a variety of new ways that patients can be diagnosed with MS and perhaps earlier than using previous criteria. And then there's also some aspects of the criteria where there's slight changes or recommendations that may improve diagnostic accuracy and prevent misdiagnosis of MS or somebody receiving a diagnosis of MS who doesn't have it. And so in these two ways, accuracy for the diagnosis of MS is improved in that we can hopefully detect and diagnose people earlier, which leads to treatment, which improves outcomes, as we know, and prevents disability. And then we could also prevent misdiagnosis of MS for patients who are given a diagnosis who don't have MS.
What was the process like for the scientific community to arrive at a consensus to update the criteria? And who was involved?
So this was truly, I think, the biggest group that has been involved in revisions to the MS diagnostic criteria since we've been doing this, which is wonderful. So it was quite a diverse group of people from around the world. They were on a committee that was organized by the National MS Society in the United States and the European Committee for Treatment and Research in MS in Europe. And the members of this committee are MS specialists with different types of expertise pertaining to diagnosis around the world in many countries. I believe there were certainly more than 50 people involved. There were also special people who were invited with extra expertise to these meetings. And there were people with MS at this meeting and people involved who held positions on different types of MS advocacy groups. So there are really a lot of stakeholders involved in this process, including the patient voice, which was, really, really important. The process was sort of an iterative process of defining what new data or research there was that might be incorporated in the new criteria through multiple meetings over time, and then presenting proposed changes to this committee when we convened in person. And then the committee voted on what should be incorporated in the criteria. And there was a predefined threshold that had to be reached that we decided ahead of time what that threshold was. And so if there were enough votes that something should be incorporated in the criteria over that threshold, it was. And then there was a process of writing the criteria and revising it to make sure that we're able to effectively communicate the changes to the scientific community. And this year, there will be 3 companion papers also with the criteria that help explain some of the changes and how to use the criteria optimally.
I'm going to circle back to that in just a minute, but first I wanted to ask you what the major impact of the update to the McDonald criteria is for someone who has MS or for someone who believes they have MS.
It's a really important question. So for somebody who has MS, your diagnosis would not change as a result of the revisions to the criteria. And this has always been the case with our revisions over time to the diagnostic criteria for MS. If you were diagnosed with earlier criteria, you would always fulfill the diagnosis of MS with current criteria. What's happened with our criteria over time is we've sort of expanded who we're able to diagnose MS with, and it's allowed earlier diagnosis, but it doesn't change an existing diagnosis. Now, there are some really important changes to the criteria that may allow us to diagnose MS earlier, as I've mentioned, in patients who are undergoing evaluation for MS. I'll just hit on these kind of broadly. Some patients have evidence of involvement of their optic nerve in the eye that we couldn't incorporate in prior criteria. And there had been mounting evidence over the last 5 years or so that incorporation of evidence of a prior involvement of the optic nerve could help us diagnose MS earlier in some patients. So that's certainly a change. There's also this concept of dissemination in space and time that prevents us from diagnosing MS in patients who have a disease that is a one-time deal. We call this a monophasic disease. So MS is, you need evidence that there's stuff changing over time, and that's what that dissemination in time aspect is. And in some patients now, we can diagnose MS just with what we call dissemination in space, evidence of involvement of the different parts of the nervous system. And we don't need dissemination in time per se. And that's a change with our current criteria. And in fact, a change that happened with the prior criteria in 2017 as well. We were able to substitute spinal fluid findings. So we don't have to wait for a change in time. We can look at that MRI and tell that things had changed in time previously. And so we don't need to wait to make that diagnosis later when something changes on another MRI. Now, also, there's been some new tools that are incorporated involving MRI that are called central vein sign and paramagnetic rim lesions. Now, these are long words, but what they are really findings that have some specificity to what's going on in the brain in MS. And if we see these changes on MRI, they give us confidence that it's MS, and they can allow us to diagnose MS earlier in some situations. And they sort of reflect some of the immune processes. MS is an autoimmune disease that we see in MS. There's a couple other really important changes that we've included an update in the type of testing that can be used in spinal fluid that may make it more accessible than the type of testing that we typically do. This is called kappa-free light chain testing. This may be easier in other parts of the world where the CSF testing that was recommended by prior criteria wasn't available or is accurate. So this may really help patients in regions where there wasn't access to high quality spinal fluid testing around the world. There's a couple of patient populations that this criteria recommends changing our approach in. So pediatric MS, we used to think of pediatric MS as being kind of different than adult MS, but we're recognizing that the diagnosis is the same in these patients, but there's particular disorder that we should do a blood test for if the patients are very young to rule out other disorders, because that diagnosis can be mistaken for MS. And so that's a different recommendation than prior criteria. Similarly, in older patients, because as we get older, perhaps over the age of 50 or so, there's a lot of causes of changes on MRI as we get older. So there's a number of disorders that are routine disorders that could be mistaken for MS. So the diagnostic criteria recommends some more stringent testing or evidence of MS in patients who are older to make sure that the diagnosis is accurate. Last, I think that sort of the biggest change in the criteria now is we are able to diagnose patients who don't have symptoms. So we have something we've called radiologically isolated syndrome. And what this scenario describes is a patient who had an MRI for some reason other than a suspicion for MS. Maybe they were in a motor vehicle accident or had a headache, but on their MRI looks like MS, but they haven't had an attack typical of MS that could allow us to make the diagnosis of MS by previous criteria. But the current criteria now allow us to make a diagnosis of MS in patients without any symptoms, but MRI evidence that is strongly suggestive of MS. And this will allow much earlier diagnosis in those patients. So there's been quite a number of changes, perhaps more than a lot of previous criteria.
We have another question from Liliana, who tells us she was diagnosed with optic neuritis. She believes she has MS, and she's wondering how the updated criteria might impact her ability to be diagnosed.
So optic neuritis is a common presentation of MS, and we certainly were allowed to diagnose MS in patients with optic neuritis through all of our criteria. So this was a typical presentation of MS. However, to make the diagnosis of MS, we require different regions to be involved for fulfillment of what we call dissemination in space. And the optic nerve, for a variety of reasons, wasn't included in previous criteria, and now it is. So this inclusion or this change diminishes the number of additional regions in the central nervous system that are required to make the diagnosis of MS. So my short answer is with optic neuritis, either a presentation of optic neuritis or in somebody who presents with another type of symptom, maybe numbness or tingling, but has evidence of older optic neuritis that maybe they didn't notice at the time. If we see there's changes in the optic nerve, we can make the diagnosis of MS earlier with fewer regions in the central nervous system required.
Joshua has been diagnosed with radiologically isolated syndrome, also called RIS. How might the updated criteria provide more clarity about Joshua's health?
This is a very important change in our new criteria. So radiologically isolated syndrome is a scenario that is sort of defined as patients having an MRI that's very concerning for MS, but not adequate, without adequate symptoms to fulfill our diagnostic criteria. And as a major change in 2024, patients with radiologically isolated syndrome can be diagnosed with MS under certain circumstances. They essentially need to fulfill dissemination in space and time, or there's some different tools that we can use to confirm the diagnosis. This will allow patients with RAS to be diagnosed earlier and for their MS diagnosis to be confirmed. We know that RAS, seems to be early MS in patients who just haven't yet manifest a symptom. Another important change sort of related to this is MS diagnosis had relied upon specific types of attacks or progressive disability to make a diagnosis of MS. Now, when we talk about RAS as patients who are asymptomatic, there are also patients who have symptoms that we might say are sort of like nonspecific or brief, or a little bit hard to sort out, numbness or tingling that can be challenging, for instance, and wouldn't meet our definition of an attack. But like RAS, patients who have such symptoms that might not have been diagnosed by prior criteria, now if their MRI shows evidence of MS, they can be diagnosed earlier as well, and we don't have to wait for an attack or relapse, as we call them, or disability to progress in order to make the diagnosis. So in many of these patients, we're going to be able to diagnose much earlier than we had been.
Cindy's wondering if the updated criteria could reverse her previous diagnosis of MS.
That's a great question. This criteria will not change the diagnosis of MS in somebody who already has a diagnosis of MS. And that's true of every revision to MS diagnostic criteria. Anybody diagnosed with earlier criteria would still typically fulfill diagnosis of MS in the new criteria. The work that's being done generally is to expand who we could diagnose MS in, but it wouldn't change a diagnosis in somebody who already has it.
Carlos says he's 58 and he believes he has MS. How will the updated criteria change diagnosis in people over 50 and other specialized populations?
So in patients who are over 50, there's a number of common disorders like high blood pressure or headache that can migraine in particular that can cause MRI changes that can look like MS. So the criteria recognize that there's a higher risk of misdiagnosis in that situation. As we get older, we all, even just normal aging can cause these non-specific changes, white spots on brain MRIs. So the criteria creates a slightly different threshold for diagnosis in older patients where a diagnosis is being considered, where some additional testing should be evaluated to confirm the diagnosis of MS. Similarly, in younger patients, in pediatric population, there are some particular disorders that can mimic MS that are very common. One of them is called myelin oligodendrocyte glycoprotein associated disorder, or MOGAD. That's a long name, but there's a particular blood test that sometimes can be helpful to identify that disorder. And because it's quite common in children under 12, the criteria recommends testing a blood test for that in children where MS is being considered. And this is an important recommendation. But otherwise, the criteria also acknowledge that MS diagnosis otherwise is the same in children and adults. There was this misconception previously that MS acts differently in children or can have different diagnostic features. And over the years, research has really shown that no, in fact, MS is quite similar in children and adults. And so we sort of unified the criteria and emphasized that it's a disease across the age spectrum in this criteria.
Ruthie tells us she's had MS for almost a decade, and she recalls all the tests and retests she had to go through to receive that diagnosis. So, will the updated criteria change or improve the experience for someone trying to determine if they have MS now and in the future?
MS diagnosis is still very challenging in some patients. And someone listening to this might be worrying that we're accumulating even more testing in this criteria. But in many patients, um, uh, a lot of the testing that I've mentioned may not be necessary. So in some patients, a single MRI now could result in the diagnosis of MS without any additional testing. So some of the tools that we have now can really improve diagnostic accuracy. This is going to vary patient by patient. MS is a very heterogeneous disease, and sometimes it can be more challenging to diagnose than others. But this criteria, as I mentioned earlier, creates a lot of new pathways to diagnosis, and some of those, for many patients, hopefully would involve fewer tests.
Stephen lives in a rural area. He travels over 2 hours to get to the nearest MRI machine and radiologist for his annual MRI exam. Will the updated criteria provide an easier or different way to monitor Stephen's MS?
We have similar experience here in Vermont. We're quite a rural area, and it's hard. The criteria do not make any recommendations about monitoring. The criteria are strictly limited to what we need to confirm the diagnosis of MS. So unfortunately, there's nothing in this criteria that would improve his ability to be monitored for his MS.
Whitney tells us that she lives with relapsing remitting MS, and she's had a few exacerbations over the past year. Could the updated criteria impact or improve her current treatment plan?
Sorry to hear that. This criteria also doesn't focus on treatment at all. This is simply an update on how to best initially give people an accurate diagnosis of MS. But there are no treatment guidelines or any focus on how to treat patients who are having continued relapses in the criteria. And that should be, a discussion with patients and their provider.
Speaking of their provider, how will MS care providers be educated on the updated criteria?
This is a really critical question. We've seen data that, while we publish these criteria, not everybody sees them or knows how to use them when we look at our prior criteria. So compared to previous revisions to our MS diagnostic criteria, I think there's quite a robust effort planned to reach neurologists in the community and subspecialists globally. So there are talks at meetings that neurologists attend. There are all sorts of efforts aimed through publications and different types of neurological societies or MS subspecialty societies, attempts to reach people. But we haven't perfected this yet, and sometimes scientific knowledge takes some time to filter out, to the people who need it. So the patients out there who are listening to this can also think about, advocating with their provider. If they're undergoing an evaluation for MS, asking them about the 2024 criteria and how their situation may or may not fulfill the diagnosis of MS based on that criteria, or if other tools should be employed. And it's good to ask questions, and any good doctor would welcome such. But I think this is going to be a community-wide effort to really educate providers around the world on how to use the new criteria, because there's a lot of changes that we've talked about.
And let's talk about timing for a moment. When can people who are in the process of getting an MS diagnosis expect their healthcare provider to begin using the criteria updates?
Well, they could certainly start using them as soon as they're published. And my understanding right now is that we expect this in September 2025. There have been a number of talks given in the community to MS specialists and neurologists about what's coming. And there will be certainly more talks and papers after that that help with implementation of the criteria. But as soon as the criteria are published, I think that providers should feel comfortable using them.
And again, if someone feels their provider isn't following the new criteria, is there anything they can do?
That's a tough situation to be in. I think looking for an MS subspecialist nearby, it's more likely that MS specialists will understand how to use the criteria earlier than doctors who are trying to do all of neurology at once. Although the neurologists who are community neurologists are very capable of diagnosing MS and using this criteria, but they are trying to be up to date in every neurologic disorder that exists to take care of their patients, and so sometimes information reaches them more slowly. If a patient is in a situation where they're concerned their provider is not sort of up to date on the criteria, they could ask them about it. And often those providers do have an MS specialist that they might go to for help, and they could do that, or they could ask for a referral to an MS specialist. Because I would expect that many of us in the field of MS would be quite familiar with the criteria pretty quickly.
Will there be changes to insurance coverage because of the new criteria?
That's difficult for me as a clinician or provider in the United States to predict globally, right? So there are some patients in some countries where if you don't have a diagnosis of MS, it's hard to get treatment. And so there are patients where we've assigned a diagnosis such as radiologically isolated syndrome or clinically isolated syndrome, where we really think they have MS, but they don't quite yet meet our diagnostic criteria. And many of those patients will now meet diagnostic criteria for MS. So in some countries, it may be easier to get access to treatment in some circumstances. But otherwise, it's hard to get into specifics, right? Because the insurance landscape and payer landscape changes so often everywhere.
And are there any other new financial impacts related to the updated criteria that people with MS should be aware of?
It's possible that, in some countries, a diagnosis could be made with fewer tests, and that might have financial consequences for the healthcare system and for patients. So that's a good thing. It's and in some countries there might not be adequate technology or access to some of the testing that's recommended by the diagnostic criteria. And there would need to be some advocacy efforts and consideration from local healthcare regulatory agencies or whatnot, that whether or not they're going to invest in these tools to, for instance, evaluate the optic nerve, or to have adequate MRI sequences available for some of these new changes to the diagnostic criteria. So in some settings, it could reduce costs, but in other settings, to diagnose MS early in some patients, it may result in increased costs. And that's something that's pretty concerning for some areas.
Well, you've shared some important details and insights about the updated McDonald criteria for diagnosing MS. What would you say is the top takeaway that you'd like our viewers to remember and use?
I think the new criteria it has some pretty significant changes. So I think the top takeaway is that this is a really big change in the field, and that we've sort of balanced um, early diagnosis with misdiagnosis and simplicity with flexibility. Overall, there's new opportunities for early diagnosis of MS here and ultimately improved outcomes in patients or prevention of disability using this new criteria. But it's going to take some time. I think that's the second point is it's more complex than prior criteria. And while some pathways are quite simple for diagnosis, others, in order to facilitate early diagnosis, are a little bit new or more complex. So it's going to take some training and efforts to implement this criteria broadly.
Well, thank you for being with us today, Dr. Solomon.
Thanks for having me.
Today's program survey has now been posted in the chat for your feedback. Please take a minute and complete it to help us create programs and topics with you in mind. Please be sure to visit the National MS Society's website for information and resources on MS, connection opportunities, and ways for you to get involved. You can also connect with an MS Navigator to receive personalized support by phone, email, or through the Society's website by chat. A recording of today's program will be posted on the MS Society's website at nationalmssociety.org/MSexpert, as well as on Facebook and YouTube. Finally, I'll invite you to join me each week on the Real Talk MS podcast, where we continue the conversation that we start here. You can find Real Talk MS on Apple Podcasts, Spotify, Amazon Music, or wherever you find your favorite podcasts. Thanks for joining us for Ask an MS Expert. We'll see you next week.